Okay, so I'm going to present on placenta pathologies in twins. As I mentioned earlier on, I'm Dr. Ndagurwa, currently working at Salimu Gabe Central Hospital as a specialist obstetrician and gynecologist, and I'm also a fetal medicine fellow. I'm going to cover placental disorders in multiple pregnancies, is concentrating on monochorionic pregnancies, and we are going to go through twin anemia polycythemia sequence, selective fetal growth restriction, twin-to-twin transfusion syndrome, and I'm not going to cover placenta previa because Dr. Verenga has already talked about that. For monochorionic pregnancies, it is important for us to know that are sharing the same placenta. The placenta size is important and determines the fetal growth of each twin. The placental territory that is allocated for each twin determines the fetal growth of that twin. And the placenta is divided at the vascular equator. So it is at that division where we see the venous return, the watershed zone, where we see the venous return and the veins will be taking up and returning to the umbilical cord. So we don't use the position of insertion of the T sign, but we use the watershed zone, which is referred to as the vascular equator, for determining the division between the placental territories. So in monochorionic pregnancies, at that point, the vascular equator, we have multiple vascular anastomosis, which may be arterial, arteriovenous, and also veno-venous. So the connections that we find at the vascular equator, they determine the outcome of that pregnancy, and they also determine the type of complications that we are going to see in that pregnancy. So the different fetal-fetal transfusion disorders that arise from the connections that are seen at the vascular equator include twin anemia polycythemia sequence, twin-to-twin transfusion syndrome, and I'm going to start off by looking at twin anemia polycythemia sequence. This condition affects up to 6% of monochorionic diamniotic pregnancies, and it's a result of unbalanced and chronic slow transfusion of red blood cells from one twin to the other, and this is taking place through very small vascular anastomosis between an artery and a vein, and these are very small vessels, less than 1 millimeter in diameter. So this can arise spontaneously in about 5% of the cases, and it usually starts after 26 gestational age. It can also arise post-laser ablation for twin-to-twin transfusion syndrome, and this occurs in about 2 to 10% of the pregnancies post-laser ablation. The problem in this condition is mainly a discordance in the hemoglobin count. The twin who is losing blood becomes the donor twin, and the twin who is receiving blood becomes the recipient twin. Like what is illustrated in this image, the main problem is the transfer of red blood cells from one fetus to the other. And in the end, we end up having an anemic fetus and also a polycythemic fetus. This does not affect the amniotic fluid volume in both fetuses. As we can see in this little image on the right side, we have normal amniotic fluid volumes in both sexes, and we have one baby who is looking whitish and another baby who's looking red, and this is the donor twin, and this one is the recipient twin. On ultrasound scan, what we can see in the donor fetus is increased peak systolic velocity on the middle cerebral artery, and the increase is more than 1.5 multiples of the median. We can also pick a dilated heart, tricuspid regurgitation, and also ascites. All these are coming up because of severe anemia in the donor fetus. Whereas in the recipient fetus, we have increased hemoglobin count, which will cause the blood flow sluggish. Hence, we are going to have a decreased peak systolic velocity in the middle cerebral artery, and it's going to be decreased by about 1 multiple of the normal median. In the recipient, we can also pick a starry sky pattern in the liver, which is mainly due to decreased echogenicity of the liver parenchyma and increased brightness of the portal venule walls. So before 26 weeks, if we diagnose TEPS, the best option would be to do endoscopic laser ablation of the communicating placental vessels, and thereafter, there's need for monitoring the fetal growth, the anatomy of the brain, and the peak systolic velocity of the middle cerebral artery almost every week. If MRI scan is available, it's good to do a brain scan after 32 weeks so as to diagnose any neuronal migration disorders. And if both babies are stable, vaginal delivery is possible after excluding all other obstetric issues at 37 weeks. If the problem is peaked between 26 and 30 weeks, intrauterine blood transfusion to the anemic twin and exchange transfusion with Hartmann's solution for the polycythemic twin should be done. And thereafter, they need monitoring every 2 to 3 days, as the plan of management can change depending on the well-being of the two fetuses. In this case, delivery by cesarean section should be performed at 30 to 32 weeks. However, if the problem is peaked after 30 weeks, it's good to do a cesarean section and to get rid of all the problems and manage the babies in the neonatal unit. The prognosis for TEPS is good if it is managed on time. However, there's a high risk of neurodevelopmental delay in up to 20% of the cases, depending on the time of gestational age. And this risk is higher for the recipient twin. Now we'll move on to a slightly different condition, which is selective fetal growth restriction. This is also a complication that occurs in monochorionic pregnancies, and it affects up to about 15% of these pregnancies. It arises mainly from unequal sharing of the placenta or filamentous insertion of the cord. For unequal sharing of the placenta, I have a diagram on my right side here, where we have one placental mass. On that one mass, we have the first cord on my right inserting almost at the center of the placental mass. And we have another umbilical cord inserting at the little corner in the periphery of the mass. Like what I alluded to earlier on, the territory that is available for each twin determines that twin's fetal growth. So in this case, we have this twin on the left side who is occupying about it, and the cord is occupying about a third of the placental mass. So it means this twin is not getting enough oxygen and nutrients as compared to the twin on my right side who has a large placental mass. we diagnose selective fetal growth restriction on ultrasound scan. If the estimated fetal weight of one of the babies is less than the 10th percentile for the gestational age, or if there is a discordance of more than 25% between the estimated fetal weights of the fetuses, or if there is abnormal Doppler studies in one of the fetuses. It is important to note that the amniotic fluid in the small fetus may be reduced, but that for the normal fetus remains normal. In this, it is the typical fetal growth restriction. We may have selective fetal growth restriction with superimposed twin-to-twin transfusion syndrome, where we'll start to see an increased amniotic volume in the bigger twin. We can, for the purposes of management, we can stage selective fetal growth restriction according to the Doppler findings of the smaller twin. So if the baby is just small and the Doppler studies are normal, it's type 1. But if the Doppler studies of the umbilical artery become abnormal, it becomes type 2, and in type 3, the findings may actually be cyclical from normal to absent flow and diastolic flow to reverse and diastolic flow in the umbilical artery of the smaller twin. Okay, I've already mentioned that we can have this condition with superimposed twin-to-twin transfusion syndrome if we start to notice polyhydramnios in the bigger twin. So for selective fetal growth restriction without twin-to-twin transfusion syndrome, that's what I'm going to talk about this afternoon. We continue monitoring growth and amniotic fluid volume and the Doppler studies as well. And the gestational age at delivery will depend on the stability of both fetuses. If both of them remain normal, we aim for about 34 to 35 weeks, where we recommend delivery by elective cesarean section. In this case of selective fetal growth restriction without twin-to-twin transfusion syndrome, the outcomes are very good and survival is about 95% for both twins. Okay, I'll move on to twin-to-twin transfusion syndrome. Of course, it's a multifactorial disorder affecting about 15% of monochorionic diamniotic pregnancies. The pathogenesis remains poorly understood, but it is mainly attributed to anastomosis between blood vessels from the donor twin and that of the recipient twin. And these anastomoses are mainly artery to vein, and they will end up being a difference in the pressure gradient from the artery and the vein, and then blood will end up flowing from the artery to the vein. The twin who is on the arterial side becomes the donor. The twin who is on the venous side becomes the recipient. In this case, the problem is to do with volume. We have a central connection that is of probably normal blood vessels, and there's significant and progressive loss of blood volume from the donor twin to the recipient twin. Like what is shown in this image, we can see that the donor twin will end up having less plasma volume as compared to the recipient twin who end up having hypervolemia, as compared to twin arterial to twin anemia polycythemia sequence, where we have a difference in the hemoglobin count, but the same plasma volumes. So in this case, the donor twin will have less circulatory volume, and less fluid will be filtered at the level of the kidneys, will end up having less urine production and oligohydramnios, and if this continues unchecked, we may end up having anhydramnios in the sac of the donor twin. Because of the reduced amniotic fluid volume, we end up having disturbances in the development of the bladder, urinary system, the respiratory system, the GIT, and the cardiovascular system as well. And this baby will be growth restricted with a discordance in the estimated fetal weight that can get even up to more than 25%. Because of the circulatory insufficiency, we end up having cardiovascular dysfunction, and this places the donor twin at an increased risk of dying in utero. For the recipient twin, we have progressive increase in the blood volume, and there will be more fluid being filtered at the kidneys. Hence, the bladder will be filling even more, and more urine will be produced, which will then result in polyhydramnios. These polyhydramnios can cause lots of discomfort for the mother, and the hypervolemia in the baby can cause hypertension and circulatory overload that then strains the cardiac muscle, and this leads to function, failure, and fetal demise in about 90 to 100% of the fetuses. Twin-to-twin transfusion syndrome can be picked early on between 11 and 14 weeks. At this point, we are looking at the discordance in the size of the amniotic fluid sacs. And we are also looking at the discordance in the fetal nuchal translucence thickness of greater or equal to 20%. One of the twins can have absent or reversed end diastolic flow in the ductus venosus, and this is usually the twin with the thicker nuchal translucency. After 15 weeks, it's a bit easier to pick twin-to-twin transfusion syndrome, because in this case, we are just looking at the differences in the amniotic fluid volumes in the donor twin and the recipient twin. Donor twin will be having oligohydramnios, and the recipient twin will have polyhydramnios. Of course, the cutoff limits for polyhydramnios are different for the gestational ages. Up to 17 weeks, we use greater or equal to 6 centimeters, and up to from 18 to 20 weeks, we use about 8 centimeters, and after 20 weeks, we use 10 centimeters. Twin-to-twin transfusion syndrome can be staged using the finding of the umbilical artery of both fetuses and also the ductus venosus. For stage 1, everything is still okay. The donor bladder is visible. The Doppler studies are normal. For stage 2, the donor bladder is no longer visible because we said they are not producing enough urine. In this case, the Doppler findings are still within normal limits. However, at stage 3, we have abnormal Doppler studies in either the donor or the recipient. In stage 4, we have fetal hydrops or death of one of the babies. For twin-to-twin transfusion syndrome, the most important tool in investigating this condition is ultrasound scan, which will also be used for surveillance as well. So once we pick the condition, we follow them up every week, we're using ultrasound scan to assess growth, amniotic fluid, and the Doppler studies of the umbilical artery, midcerebral artery, and ductus venosus of both fetuses. There is a first stage where we can just pick a discordance in amniotic fluid volume. but it's not bad enough to be to fit the criteria for the oligohydramnios polyhydramnios sequence. In this case, we just have a discordance, but it does not fit into the oligohydramnios polyhydramnios sequence. If we are at this stage, the survival rate is good. More than 95% of both babies survive. However, the condition can actually progress to twin-to-twin transfusion syndrome in about 15%. Because of that, such a pregnancy will need to be monitored every 2 weeks and to follow up on the evolution of the condition. If we are at stage 1, where we said the donor bladder is stable and the Doppler studies are normal, the survival rate for both fetuses is about 85%, and for at least one twin is 90%. However, this condition can progress to stages 2 to 4 or 20% of the cases. This stage needs monitoring with ultrasound scan for growth, amniotic fluid, and Doppler studies. If there is progression to stages 2 and 4, it's advisable to do endoscopic laser ablation of the communicating vessels. For stages 2 and 4, it depends on when the condition was peaked. If it was peaked before 28 weeks, laser ablation of the communicating placental vessels will also help. And if it's peaked after 28 weeks, it's better to deliver by cesarean section. And of course, the timing will depend on Doppler findings of both twins. And this will help us to plan on the most appropriate timing for delivery by cesarean section. For the survival rates, for stage 2, it's quite good. The overall survival rate is about 75%. And for at least one baby, it's 85%. For stages 3 and 4, the overall survival rate is 60 to 70%, and survival of at least one twin is up to 85%. However, these babies are at risk of neurodevelopmental impairment, and this can affect up to 10% of the babies. So post-endoscopic laser, the pregnancy needs to be followed up, of course, using ultrasound scan every week until the symptoms and signs have resolved and the Dopplers have normalized. And thereafter, we follow the pregnancy after every 2 weeks. And of course, it's also good to assess for brain damage. In the follow-up, it's important to assess for recurrence of twin-to-twin transfusion syndrome and development of TEPS. After laser, the symptoms are expected to resolve gradually, and we start off with the amniotic fluid normalization, which can occur up to 1 week after the procedure, and the cardiac dysfunction may take up to 3 to 4 weeks. And there's a complication of amputation due to thrombotic events or amniotic bends, which can occur in 1 in 1,000 cases post-laser. If the baby is stable and all the obstetric issues are in control, the pregnancy can be delivered vaginally at 37 weeks. Thank you. So at this juncture, we are going to get questions for my presentation and that of Dr. Slaviana and Dr. Alojai. Okay, someone was asking how they can join the fetal medicine unit Zimbabwe. It's Iwango. You put your email address. Our secretary is going to get in touch with you. Okay, do we have questions for Dr. Slaviana or Dr. Alojai or myself? Dr. Verenga?
Hello, yes, Dr. Ndagurwa. I wanted to ask both Dr. Slavian and Dr. Alojaili, how best we can screen for placenta accreta spectrum or the PAS spectrum in low resource settings. Because in this meeting of obstetricians, fetal medicine specialists, sonographers, radiographers, what is the best strategy that we can employ to screen for these conditions so that we can convene the MDTs, we can also have 20 people in theater? Well, sometimes they are picked incidentally when people are already in theater.
I think before the screening should be the prevention. And this is very difficult everywhere in the world to reduce the rate of C-sections and therefore the placenta percreta spectrum as well. But in the low resource settings, without ultrasound, I don't think there is a chance to screen for placenta percreta. And what I know from Samira, for example, what they do if they don't know that it is placenta percreta and suddenly the team finds out during the delivery while they are doing a C-section, if there is no bleeding, what they do is they will stop the C-section. They are not going to do any further operation without an experienced team. Even they can close the abdomen and send the patient to a placenta percreta center. But this is, of course, Austria, where they have helicopters, where they can move the patient. Everything is very easily done. I don't know if I can find the solution without resources. You need people, you need machines, you need blood, you need medications. Many people are involved in the treatment of placenta percreta. I don't know if you have answer, Claudius.
If I can say something about that, because I'm in the placenta creator center. First of all, establish a placenta creator unit in the fetal medicine unit. And this is a placenta creator, screening. For example, if any of your colleagues has any suspicious of placenta creator, then they send to the center, which is in Harare, and you establish the that's what we have done in Romford. Establish a team, surgeon, at least 2 surgeons. If surgeon not available, the other surgeon would be around, and 1 anesthetist has good experience, and 1 neurologist, and 1 radiologist or intervention radiologist, if they if you have in your country intervention radiologist. And then if you have any suspicious, then an MRI should be done after the ultrasound. If you do the ultrasound and you have suspicious, then an MRI should be done. After we have all the results, if we have patients with 2 or 3 cesarean section or 1 cesarean section, and we have suspicious of placenta accreta spectrum, then we meet in a day and decide what's the best course of action. Any suspicious of a placenta accreta or going to the bladder or pericreta, then the urologist will start first, and the urologist will do the stent, and before we do anything with the placenta or the delivery. So for both ureter, and the anesthetist will do his part with the reduction of the blood pressure during the operation, and the radiologist will give us his experience about MRI if there is really suspicious of pericreta, and intervention radiologist, his job is to do the aorta balloon if it is possible there, but I think it's not possible. And even though in UK not every hospital has people who have experience with aorta balloon, but as I show you, this Jaco catheter will help a lot. So to reduce the blood loss. And the other patient, the other contributor is the hematologist, which is one of the most important people who will help us to be prepared for the blood if we need it during the procedure, which high likely we will need blood during the operation. And after that, I think after you establish this team, so then you will see the referral, and by the time when you establish this, you put the criteria for the referral. So for example, previous cesarean section, and any operation on the uterus, for example, any miscarriage with a surgical intervention. So kind of things, a criteria for the referral. And afterwards, by the time you will have the experience, after you see, many, let's say, cases, and if you need any help, for example, of, let's say, any case, you can send us the case. I'll present it to my lead, and then we will give you the advice. What's the next? What's our opinion about that? So it's kind of, multidisciplinary team is the key actually to deal with this kind of high risk patients. MDT, it will help a lot. And after MDT in 2015, actually, so we had a case with the patient was, died because of sepsis, before 2015. But after the MDT approach, there was no any kind of complication like death or something like that. So either hysterectomy or excision of the anterior uterine wall. So, and all cases had good results. This is my opinion actually for the establish placenta accreta unit in the fetal medicine department. So that's what I think it will help a lot. By the time you will have a good experience, and if you need any help, we are more than happy to help. Thank you.